ICU challenges, and essentially we are going to take 2 challenges only, and we have one more session on the 25th where I hope to present a few more. But today we're going to take 2 challenges: persistently low cardiac output after tech repair in an infant, and then persistent desaturation after Glen shunt. So I'm asking you, putting up a scenario. You're called to help with to manage a 6-month-old operated child for tetralogy who's developed what is described as a low output state 10 hours after she reached the ICU. You're not familiar with the details of the child. We're going to ask you how you'll proceed. You've just been called to the ICU. What is it that you will do first? So you can straight away, I'm going to turn the chat button on, and you can all start to put up your answers as to how you're going to try and manage. Next, what are you going to do? So you don't know about the details. Would you want to find out? So check pre-op details echo. Divyesh is already writing that down, and that's correct. And that's how we start. We essentially, I think you didn't understand my question. So essentially, we try and get a comprehensive preoperative diagnosis. Perfect. Then what do you do next? You get a complete report on the surgery. What happened during the surgery? As far as possible, you try and get that report. You're not familiar, so you try and understand what's happening. Next, what do? Try and understand what was the hemodynamics on arrival. Okay. Next. So you make a complete assessment to confirm indeed that this is a low cardiac output state, and then try to determine the possible cause. Okay. Once you have done that, you make sure you obtain an ECG. It's important enough to actually write it down separately, and of course you do an echocardiogram, which will try and 80% or 90% of what you are worried about would be sorted out right there. So I'll give you the preoperative details. This was a 7-month-old 6 kg tetralogy with, within quotes, good overall anatomy. It's just done by echo. We didn't do any further investigations. 6 mm branch PAs, normal coronaries, 7 mm PVP annulus, single VSD, and nothing obvious as far as aortopulmonary collaterals on echo. And there's a small PFO that was shunting bidirectionally. So this is the case that we are finding, and we are finding that the child is in low output state. The surgical details, I'll just give it to you. The correction was the usual: VSD closure, infundibular resection, and you would recognize that a 7 mm annulus in a 6-month-old is inadequate. So it's transannular patch. The surgeon said that there was impressive returns, but it was essentially otherwise okay. The CPB time was 110 minutes. Cross clamp time was 70 minutes. He didn't have any difficulties coming off bypass. There was modified ultrafiltrations. RV pressures were a little over half systemic when she came off bypass. PFO was left behind. Supports of adrenaline at 0.04 mics per kg per minute. TE was done, showed good repair, no residual VSD, and then the patient came to the ICU. The patient was stable for the first 6 hours, and after that he started to develop persistent tachycardia with heart rates that started to go as high as 180, cool extremities, lactates that were high or moderately elevated and that kept getting higher, urine output that was rapidly declining, and surgical drains weren't significant. But would you like to know anything else at this stage? Yeah, so the blood pressure was in the 60s. Did I write that down? I think I missed that out here in this slide. So BP was 80 by 50, mean of 60, at a decline to 65 by 40, mean of 52. The CVP was varying between 8 and 12. The supports was increased gradually, and eventually adrenaline was 0.1 when you actually came to the ICU. The ABG showed no acidosis. PO2s varying between 70 to 94 millimeters mercury. So what would you like to conclude at this stage? What would you like to do? What's your next step? First, baseline, bedside, what do you want to do? So I'll go back and tell you what the stable for first 6 hours, heart rate in 160, 180. These were the trends. This was how. Before I go on to the causes of low output state, anything else you want to do? Okay, what's your checklist of causes? What are the possibilities? What are your list of causes now which you want to think of? Now you start telling me. So you want to say that first? I wouldn't want to say that first. The first thing would be, so maybe SIRS, which Divyesh says, systemic inflammatory. It's a little early for, isn't it, for a systemic inflammatory, and it isn't something that is so specific in terms of cause of low output state. Again, something that you would not like to put first on your list. You'd like to put the most preventable causes. Okay. LV dysfunction, not really. Again, not something that I would put first on the call. Bleeding. So bleeding that basically you've had no drains coming out, but it's possible it's all collecting inside. So I think that's very important. But before that, rhythm. I mentioned that the heart rate is 180 per minute. The first thing you'd like to rule out is a junctional ectopic tachycardia, which in these circumstances will produce low output state because of the fact that tetralogy, the post-operative state, is very dependent on atrial kick. Pericardial and pleural collections, even pleural collections, if they are very substantial, can produce a low output state without actually there being a pericardial collection. Hypovolemia, absolute and relative. So these are readily preventable causes. Only then you start talking about things that are you can't do too much specific treatment about. We'll talk about. Then you come to residual lesions. Okay, in your checklist. Then you start talking about things like, okay, bypass and cross clamp related low output. Sepsis is way too early for sepsis, but it's something that you can put lower down in your list. And others, which is what we will discuss in terms of restrictive RV physiology. So the CPB and cross clamp related low output state has a basis, and you need to state the basis very clearly. What is the basis of CPB and cross clamp related low output state? So one is the inflammatory response associated, which is what they call it as systemic inflammatory response or SIRS, and then effect of myocardial ischemia from aortic cross clamping. So when you cross clamp the aorta, you have the possibility of the myocardium getting ischemic, even if you administer cardioplegia correctly. Then hypothermia. So you have to recognize that hypothermia is one of the most important cause of ventricular dysfunction early after surgery, and therefore that rewarming phase, when they come off bypass, they gradually rewarm and then let the heart come back, and the heart myocardial function picks up with that. Reperfusion injury. So reperfusion injury is very important because once you reperfuse, particularly those patients who are hypoxic, have a higher than usual tendency for reperfusion injury because their reserves for oxidative stress is much less. And that's again coming into the restrictive physiology. I will be discussing that at length. And then comes inadequate myocardial protection. If there is incredible left ventricular or right ventricular hypertrophy, your cardioplegia may not reach all layers of myocardium. So that's another important area. And when you do ventriculotomy, you can, just by the fact that you do a ventriculotomy, result in ventricular dysfunction. A right ventriculotomy can result in a left ventricular dysfunction because the fibers are shared. So you have a multiple basis for a post-CPB related low output state. Okay, this was the ECG. What is your interpretation of the ECG? What is the diagnosis and what will you do next? What's your diagnosis? Now somebody said jet, but are you sure it is jet when you see a consistent P wave before every QRS complex here? It seems to be pretty consistent, Srinath. It's not. I'm just going through this particular lead, and I don't find a single lead where P wave is not before the QRS complex. It still, even if you think it is varying slightly, even this kind of a long strip with this many QRS complexes, you can't have a situation where before every QRS complex you have a P wave. So anyway, you are in doubt, isn't it? There is, you are saying it could be, you have said jet, somebody else said sinus. So what do you do next? So you do an atrial wire study. Okay, so that's very important that you actually do an atrial wire study, and it turns out that this patient had a, what does it have? What is the rhythm here? So when you interpret an atrial wire study, you realize that you must always have one surface, and you must have two atrial wires. You must have one surface to decide which is the QRS complex. So you know that this is the QRS complex. So you have A wire and surface, and you have this red lines come on the QRS complex right there. So you know that the one just before that is the A wave, and that coincides with these tiny little A waves that you're seeing on the surface ECG at the bottom. Okay, and then of course you have the V waves, which are shown by these white arrows which came down, not very clear, but you can understand. So therefore an atrial wire ECG will tell you that this is jet or not. When you have jet, and Srinath gave me this ECG, you can have the inconsistent association between the P wave and the QRS complex, and it's particularly evident out here. Here you can clearly see this P wave is way too short, the PR interval, to have actually been conducted. Here these three are okay, and then when you go on, here clearly you are having AV dissociation. So this is an example of AV dissociation, and when this rate is much faster, you say it is jet. I'll give you one textbook example that I actually took out, which you can see here. It's very obvious in this particular textbook example that it's very clear that you have AV dissociation. It's jet, which I couldn't actually see a better example of. Where you can clearly see there is complete AV dissociation, and there's a very fast heart rate. So if you have the same A wire study shows AV dissociation in the face of a heart rate of 180 dealing with junctional ectopic tachycardia. And I think that's the first step when you encounter a low output in a condition such as tetralogy. Jet, well, it's actually not uncommon. About 5% after tetralogy, some situations 10% have jet, and jet is devastating. Mortality is higher. The low output state association is very high. So you should definitely then manage jet specifically based on the principles of management, which is worth re-emphasizing at this point, and that is excess catecholamine. You take care of analgesia, control temperature, induce a certain degree of moderate hypothermia, reduce exogenous ionotropes when feasible, often it's feasible, correct, optimize magnesium, calcium, and potassium, and then you initiate specific therapy early with amiodarone. Overdrive pacing whenever heart rate permits, and cardioversion is not useful. I have seen some instances where we were shocking patients without clearly defining the fact that this was a jet 5 or 6 times, and that is unacceptable. It does a tremendous amount of damage. So here is the Brisbane protocol that I actually downloaded, which I find is most effective in patients with jet. I'm sorry. So when there is a postoperative tachyarrhythmia, you do confirm diagnosis with an atrial 6 or 12 lead ECG, do an A wire study, and if necessary give adenosine while you're doing A wire study if you're not sure. In these two instances, we were pretty sure when there's AV dissociation, you don't need to give adenosine. But when you're not sure, when you're not able to see P wave, despite A wire, give adenosine and you can separate them. So then amiodarone bolus 5 mg per kg over 16 minutes, IV, followed by all those things. So give amiodarone at the first instance when you diagnose jet, then control temperature, administer potassium to keep it around 4, give normalized calcium, administer magnesium. Whether or not you just give it, you don't have to determine levels. You can safely give magnesium in the bolus that has been suggested, and then optimize pacemaker. Always check, and I think this is a very significantly neglected situation in the ICU. We don't spend enough time in defining how best we are pacing the patient. So if we can get the rate around 150, jet at 150, and the patient is not doing well, pace at 155, 160, you'll get AV synchrony and you'll have much better hemodynamics. So it's worth doing that, and decrease catecholamines whenever possible. Often you are able to. In fact, one more thing I'll add here, sometimes you may need to optimize preload, give a fluid bolus, and then try and decrease catecholamine. reassess diagnosis and rate every 2 hours, give your second amiodarone bolus after 2 hours. If it is not effective, reassess, then give the third bolus, and usually with that you get control, and once you get the control, you start the amiodarone infusion. This is different from the protocol where you used to give a single dose of amiodarone and follow it up with the infusion. So you give multiple boluses, and this is something I was repeatedly emphasizing, and I think this achieves control, and being really aggressive about controlling jet is one of the secrets of managing them, and giving amiodarone early and giving it as boluses is the answer. So that's about jet. Okay, now we go back to our checklist. Echo is the next step, and echo will address many aspects in the checklist. The first thing I told you about was rhythm, and that is with ECG and with AVAR ECG. And next is echo. So let's look at the checklist and look at what our patient had. Collection. So we did a systolic function, which is LV dysfunction, VSD patch, tricuspid regurg, right ventricular outflow tract, branch PA flows, PFO, and other specific issues. So we look at it. So our patient had no collection, normal, actually vigorous function. VSD patch was intact, no residual VSD, no TR, no RVOTO. In fact, there is free wide open RVOT and free PR. Okay, branch PAs symmetric and okay. PFO small, now it's right to left. Actually, not too small. I'll show you, and other specific issues we'll go on to. So we have a situation where echo is not showing anything clearly positive, but you need to look at echo more carefully in this situation. So this is a very familiar story. I think most ICUs, some point or the other, would encounter a tetralogy repair with a transannular patch who starts to become sick in the ICU, not having issues in the theater, and typically with hypotension, cool extremities, low output, high lactate, high CVP. So this is of course the restrictive physiology, but let's talk about it a little bit more in detail. Echo is showing good BS repair, and you often end up giving more and more ionotropes, more and more compressors, and these children can end up with a turbulent course and varying degrees of end-organ injury, and the morbidity is substantial. Mortality also is much higher than usual. So if you look at this echo, for instance, this is not uncommon. So what's this? What are you finding here? So dilated IVC with absolutely no change. Well, actually they won't collapse if the patient is on positive pressure ventilation. So you won't find collapse, but you can see that the IVC in this little child has become almost 1.5 centimeters. Okay, and then in this very view, you also see the same thing where you actually don't see any change in the size of the IVC, and you're finding that this patient has significant enlargement of the IVC. Okay, next. So what do you want to interpret here? What do you find? You want to interpret this? So there's flow reversal, and that flow reversal, if you actually time it, we haven't timed it here, is going to be late diastolic. Okay. Okay. Now what is the finding here? I've labeled it for you. So there is a PFO with predominantly right to left flow. Okay. So now next. Now this is the fun part of it. So this is the tricuspid valve, and what do you find? What do you call this pattern? This is normal. What do you call it? Pseudo normalization. This is actually not normal, but pseudo normalization. It's not actually it's not severe TR. It is just a small jet of TR that happened to be picked up. Dr. Vinu. We haven't actually done a color Doppler, and the color Doppler did not show a significant TR. This was meant to describe the diastolic filling pattern. There is definitely TR, but it isn't very severe. It's a pulse Doppler, remember, so you will get aliasing at very low velocity. Okay. Okay, now try and interpret what's happening in the right ventricular outflow tract. So you'll agree there is free PR. You'll also agree that there is no turbulence. That's very good. Now here is what I want. What do you see here? Are you perceptive enough to find what's happening? First of all, you can see that there is pretty good flows in the branch field, no doubt about it. You are seeing flow reversal in the branch field. You're seeing something else. What are you seeing? Maybe not possible for you to pick up now. I'll put a pulse Doppler into this and to ask you what are you seeing. Okay. Remember this pulse Doppler. This is early diastole. Then this is systole. So what are you finding? So this line is at the start of systole. This is point where systole ends and the diastole starts. This is something I'm going to ask you what it is. What is it? So late diastolic forward flow. Absolutely, it is the late diastolic forward flow that you're seeing. So this is classic restrictive physiology. You're not supposed to see late diastolic forward flow deep inside one of the branch VAs. Okay, so that's something which is clearly suggested. Your right ventricular and diastolic pressure is extremely high, high enough that is able to actually allow blood to move forward during diastole, and these are reflected A waves in the pulmonary artery. So if you actually do a color M mode, you can see that really well, beautifully. This is the RVOT flow during systole, that is turbulent. This is the PR flow during early diastole, and this is the forward flow during late diastole. And seen even better here, you can see the late diastolic forward flow within the branch VAs using color M mode, which actually lets you resolve all this very nicely over time. So preserved RV function, poor filling in late diastole, high RVETP, forward flows into PA in late diastole, high CVP, right to left shunt via PFO. Classic story, low output state, and this is classical of what you see in tetralogy, and one of the commonest causes of patients doing badly after surgery. So what is the basis? This isn't as simple as you think it is. People haven't, there has been a fair amount of work on this, but people haven't really thought deeply into it because we, So what is the basis? So acute restrictive physiology is associated with greater myocardial injury, intraoperative injury, post-operative oxidation stress with severe iron loading of transfer, and I'll explain this whole thing to you again. The second step is something that isn't very intuitive, but invariably, if you actually go back and think about those patients who develop the low output state, in our own experience, you will find that their bypass times and support times were longer than those in which you didn't encounter any problem. So the myocardial, intraoperative myocardial injury is something that is clearly associated with restrictive physiology. I'll explain this in the next slide where there is post-operative oxidative stress. I mentioned to you that these are patients who are hypoxic and not accustomed to a sudden oxidative stress load because that it results from improved oxygenation. So that's something that we have to understand, and of course iron loading of transfer. So I'll explain that to you also. So this is a paper that I would encourage you all to read, which is this is a paper that I'll encourage you all to read, which is acute right ventricular restrictive physiology after repair of tetralogy. And this is something that really people have tried to understand at great length. They compared. This is a paper which came from London when Dr. Reddington and Dr. Chaturvedi, Rajiv Chaturvedi were working there. And they actually tried to look at it very deeply, and they found that basically there were two groups. There was one group that had restrictive physiology and the one group that did not have, and the numbers were actually quite small, 7 in the non-restrictive, 4 in the restrictive, but they studied them very nicely. The arterial troponin T levels were much higher, both the peak levels as well as the area under the curve, which is the total release of troponin T, was much higher in the group that had myocardial injury, that group that had restrictive physiology, as against the group that did not have restrictive physiology. Although there was differences in bypass times, because these numbers are very small, the difference did not reach statistical significance. But you can see that this was 110, this was 83, and this was somewhat lower. And in our own experience, we have really found that restrictive physiology is invariably associated with long bypass duration. Then they measured first myocardial injury, and some level they measured the oxidative stress by means of this NOx, which is basically a measure of oxidative stress, and they found that the total ratio of NOx to creatinine clearance 2 hours after bypass was certainly much higher in the group that was having restrictive physiology. The total ion binding capacity was considerably reduced in the group with restrictive physiology, and the transference saturation was considerably higher in the group with restrictive physiology. So clearly, there was some form of ion overload in this situation. So this is the troponin T levels in the group with restrictive physiology and the group that is having non-restrictive physiology, and persistently there was a difference. So this is the hypothesis that we put together. I sort of put together based on what I've read in this paper and on a few other elements of understanding. Essentially, the bottom line is suboptimal myocardial protection, which can result from unsatisfactory hypothermia. And it's important to recognize that unlike the left ventricle, the right ventricle is very anterior. It is right under the surgeon's lights. So you can actually not get that much of hypothermia in the right ventricle as compared to left ventricle. The right ventricle is very much more vulnerable to poor myocardial preservation. Non-homogeneous delivery of cardioplegia with severe right ventricular hypertrophy is more likely to result in islands of poor perfusion, which results in myocardial injury, and of course long bypass and cross clamp, excessive muscle resection. All this comes together and results in, and we used to see it time and again. If you combine long bypass time, severe right ventricular hypertrophy, transannular patch, excessive muscle resection, you had the setting for a low output state. So this is a stiff ventricle with restrictive physiology. And the other thing is the sudden increase in oxygen concentration at the time of surgical repair. This is basically resulting in oxidant damage, and because of the down regulation of antioxidant defenses as a result of chronic hypoxia, there is increased vulnerability to oxidation damage, and there is also free radical generation, and generally there is a lot of redox active ion which can result from either polycythemia or CPB induced hemolysis. So there is a lot of free hemoglobin, and this free hemoglobin tends to have much more redox active ion, which generates free radicals and increases oxidative damage. Even the systemic inflammatory response results in extravasation of ion binding proteins, which increases redox active ion and then can do the same thing. Inhalation, increased levels of nitric oxide also are known to produce this kind of damage. So a whole lot of mechanisms for oxidative damage in these circumstances, along with myocardial injury. So the implications really is that most important is to prevent and leave behind atrial communication. There was a time when in tetralogy they used to suture the PFOs and the patient did much worse, especially in infants. Atrial wires are very useful. There was a time when they were not putting atrial wires and using isofrenylene to step up atrial rate, and it used to be disastrous with high incidence of jet. Surgical times are shorter the better, and we've seen that. Special attention to myocardial preservation and cardioplegia. Preserve pulmonary valve whenever possible, and we've again seen the ones where we come up with no PR, just fly through the ICU. Avoid hemolysis. Very, very important. If you have hemolysis, the incidence of low output state is very, very high. Minimize RV resection, and that's again a trend to minimize. People don't cut the moderator band these days. There's much less resection that happens today than used to happen some time ago. And then maybe a lower hematocrit may help, but we don't have data on that. Management, optimize preload, accept higher than usual CVP because there is restrictive physiology, and that's more important than pushing up inotropes. Accept low PO2 when PO4 is left behind. You can even extubate with a PO2 of 60. That's fine. And strive hard to maintain the atrial contribution to cardiac output. So atrial pacing or AV sequential pacing when needed is very important. Avoid inappropriate tachycardia because your diastolic filling has to be better. Aggressively manage jet, and we know about that. Low airway pressures. Even early extubation helps because that will improve filling in the face. If you have positive pressure respiration, it comes in the way of filling of the right ventricle. So if you have negative pressure ventilation, it improves right ventricular filling. So we tend to extubate early, and that's a tendency you might have seen even if there is borderline low output state. Unless the patient is having really cool extremities, we tend to extubate early. So what is unhelpful is progressively increasing the dose of inotropes and pressors and have more tachycardia and myocardial injury. That's not a good idea. Calcium infusions, not a good idea. Digoxin, not a good idea. And I'm not so sure about melphalan. Extremely controversial, and I think it's dangerous because you can have a situation where you vasodilate, and in a state where you're actually relatively hypovolemic, you may end up with a situation where you increase the hypotension considerably. Futuristic, this is something I wanted to think about, trying to give some kind of free radical scavengers like N-acetylcysteine in the right kind of time window. I think this is something that needs to be studied. It's completely experimental, and this may be a useful way of preempting those situations where we think patients are at high risk. Okay, any questions from this case scenario? And then if time permits, we'll go on to the next case scenario. We're already at 6 o'clock, so we could probably do it within the next 15 minutes. Any questions on this? Do you understand the situation with restrictive physiology? This is exactly what I've been wanting to actually get through to the surgeons without much success really. I've never got them to actually listen to this presentation, and I think they need to understand this with a little more depth. I think there is an overuse of inotropes in these situations. And how much CEP to accept? It's a good question. It's relative. I'm usually, I think if I have to pick on a number, somewhere around 12 is okay. I'm happy with up to 12 as long as I can get your BP to be maintained at that level. I'm pretty happy at that around that level. 8 to 12 is what I like in these circumstances. Less than 8, you can be relatively hypovolemic in the context of post-op tetralogy. So that's my number. But I think there might be differences in other individuals in the way they approach this situation. Okay, I think we'll now take a next case number 2. Okay, case number 2 is a 3 month and 19-day-old child with 4.9 kgs with single ventricle physiology, essentially a very large inlet VSD amounting to single ventricle. She was quite blue, periodically very blue. Aorta from RV, pulmonary atresia fed by a restrictive PDA, good size Hyler PS, bilateral SVC. So what's your recommendation? What surgery will you do now? And Srinath, you need not answer this because you know this patient. Supti. The pulmonary blood flow so much that you may not make them a good Fontan candidate eventually. So if at all you can avoid it, I would avoid that step and try straight going to a Glen. Okay. So yes, the answer is Glen, and a little early, but it's still a pretty good option. All right. So we did that. And we have now a surgeon who seems to want to do it off pump. Of course, the fact that this patient had bilateral SVC was very helpful in doing an off pump Glen, and the patient did well initially, uneventful. SATs were not great, high 70s. PO2s between 38 and 44. He was extubated first post-op day and put on BiPAP for low SATs. So that was a bit of a warning bell, and we did that. All right. But from day 2 to 5, his saturation never picked up. On day 5, we started to sit on the 60s, and he was reintubated. And then things like sort of things got clouded. More supports were added. There was a suspicion of sepsis. All kinds of things were thought of. So we reached a situation where we were having a child who was reintubated on day 5 after a Glen and was having persistent desaturation. So now I'm going to go through a post-Glen desaturation checklist. There are 10. I've made it 10 because all checklists you should have 10, not because there are 10 causes. There could be more. So come on, give me reasons for desaturation after Glen. Start systematically. Start from the SVC. Anastomosis. So I agree. The first thing is could be anastomosis. Before that, respiratory causes. Always think of respiratory causes first. More causes, anastomosis, obstruction at Glen anastomosis. Okay. Decompressing veins. We're going down from SVC to branch PAs, branch PA narrowing, increased pulmonary vascular resistance, pulmonary venous hypertension, elevated LA pressure, ventricular dysfunction. Ventricular dysfunction will cause problems upstream, that is high Glen pressures. But how does it produce problems downstream? For example, if you ask me why does anemia produce desaturation after Glen, can you answer that question? Someone said collaterals. Collaterals usually do not produce, maybe venous collaterals, but not arterial collaterals. So, how can anemia produce desaturation in a Glen circuit? How can ventricular dysfunction produce? How can reduction in systemic cardiac output produce desaturation in Glen? Have you thought of it? Has anyone thought of why you have?
PA flow is dependent on the cardiac output. So the cardiac
No, that's not the most obvious answer. The correct answer, why should anemia produce it? So basically, it increases tissue extraction of oxygen. Your mixed venous blood saturation falls. Your mixed venous saturation falls, that goes right across. That venous saturation goes straight into the aorta. You're having essentially complete mixing of the IVC blood within the heart. As a result, anything that produces a low mixed venous saturation would translate into low systemic saturation. So the one number you have to pick in a patient with Glen about whether a Glen is doing well or not, just one number will tell you, and that's saturation. If your saturation is in the 90s, you're doing well. If your saturation is low, it could be one of 9 or 10 things. Anemia, hypovolemia, low cardiac output, but also respiratory causes, pulmonary vascular resistance, everything. So, sepsis to complete the list. Okay, so you have a long checklist of causes early after Glen desaturation. If it is late, you could think of pulmonary AV malformations also. But early post-op, you don't think of pulmonary AV malformations. You think of these 10 causes. So in our patient, let's look at what happened. Well, respiratory causes, he had a normal chest X-ray, normal airway pressures, no significant secretions. We didn't think of reasons to have respiratory causes. Obstructions, well, the pressures were not elevated. Okay, then branch PA narrowing, echo was fine, did not show any branch PA narrows, but we can look at it. Increased PVR wasn't reflected in the SVC pressures. Pulmonary venous hypertension, there was no substrate for pulmonary venous hypertension and the pressures were normal. Elevated LA pressure wasn't the case. There was no AV valve regurgitation or stenosis. Ventricular dysfunction, echo was showing good ventricular function. Anemia, hemoglobin is 14.8. Sepsis was ruled out as best as we could. Labs counts and cultures were consistently negative. So we are left with the 10th cause, which I brought down the list, which is decompressing venous collaterals. So the answer to that is to do a contrast echo. I wanted to ask that as a question, but I've given you the answer. The best way to rule out a venous decompressing collateral is to do a contrast echo. So you have to do, in this particular case, bilateral BDGS, you have to do a contrast echo in both the arms, right arm and left arm. And we did one in each arm, and we found that almost instantaneous appearance of bubbles in the right atrium after injection in the right hand. I don't know if you were there in the ICU. Almost instantaneous. The patient was severely desaturated, and we found this very interesting thing. So what do you do next? What do you do next? Can anyone answer what should you do next? It's very obvious. So you'll have to close them. You have to take them to the cath lab. Okay. So we'll show you those pictures. So it's very impressive actually. So this is what. So can someone point out what's happening? Which is the likely decompressing venous collateral? Venous collateral that you're seeing. Which vessel is the likely culprit here? It is usually tied off for some reason. In this particular case, wasn't tied off. Azygos. You can actually see the azygos very clearly, and the azygos is seen as this blob out here. Of course, it's much more beautiful in the lateral view, but you can see that it's going way down parallel and then draining back into the heart. See that? So then we went in, defined it, and applied it. And you can see in the lateral view that azygos is going posteriorly, and after that, of course, the patient did rather well, and almost next day we could extubate him, uneventful recovery thereafter. So this is a very important checklist to go through the next time we have somebody with Glen. You have Glens who are little infants who will have desaturation for 2-3 days. We have one right now in our ICU. A little infant, particularly if they have total veins, they've been through a bypass run, the PVR is relatively high. So the first 2-3 days can be turbulent and they can have low saturation. But on day 5, day 6, if you have persistent low saturation, it's a matter that needs investigation. And that needs to be investigated through cath, through very aggressive means, through a contrast echo and then through cath. So the bottom line is, in somebody in the ICU, if they're not progressing on expected lines, there is a need to answer the question why very quickly. Otherwise, you can lose the child. Anyone who's stuck in the ICU, don't accept it. We need to keep asking why, and then usually you have an answer. I think that's it. I don't think I have any more slides, and thank you. Any questions from you? Answer.